Peace be to you. This is Omar Abdul Malik, physician assistant and health educator. Okay, so doing my Wednesday run. Today's topic is for you guys that are pre-PA students, PA students, and some medical students, if you don't mind listening to a PA. Hi there. I'm going to talk about surviving your surgical rotation. Now, your surgical rotation can range from anywhere from 4 to 6 weeks, depending on where you go to school. And it may be one of your toughest rotations because so much is required of you. Really, really long hours. You know, there is hazing under the auspices of training you that goes on. I call it hazing, but it's good for you, as I will explain. You've got long hours. It may be 6 a.m. and you may not get off till 6 p.m. And keep in mind, you're just a student at that point. So my surgical clerk rotation, I didn't pass the first one. The chief resident flunked me, but the attendant gave me very high marks. So they kind of, I think my program directors or somebody, you know, said, okay, we'll take an average and really try to take a balanced approach. So they passed me. Well, they didn't, no, I didn't pass it, but I didn't have to sit out of the program for a year. I got to take it again, which was good for me. But your surgical rotation will go like this. You may start round at 6 a.m. And then you have to round on every patient with the entire team. Your team may include medical students, pre-meds, and medical students and PA students, and the residents, starting with the intern, and the chief resident, and then maybe an attending may round with you guys, depending on the day. So, what who was ever in charge, whether it's a chief resident or attending, what they'll do is they'll ask you questions about a patient. So, as a student, you may be assigned a patient. You need to know everything about that patient, about that surgical patient, everything, and use as your basis your knowledge of pathophysiology. So you need to understand the etiology. Let's say the patient. So my typical patient 20 years ago at DC General was a status post multiple gunshot wound. Say you have a 22-year-old African American male, status post multiple gunshot wound to the thorax and abdomen, status post chest tube placement, right side, JP drains. So you need to know everything about how to manage a patient whose status post gunshot wound. If they have JP drainage, you need to know how much output was in those JP drainages. Are these tubes that they put in people's maybe their chest or their back or stomach if they need to drain like serosanguinous fluid or pus or something. You need to know the output, how much output has been accumulated in the past 24 hours or over the last time you were there. Is that patient, if that patient has a chest tube, was there output from that chest tube? Is it, what's the quality? Does the person have a Foley catheter or what we call a condom or a Texas catheter? Is the patient alert and oriented? Maybe the patient has got altered mental status, AMS, and that could be a sign of sepsis. First and foremost, what are their vital signs like? You have to know that. If the patient had a patient who was status post gunshot wound, guy had septicemia. He had something called a PICC line in. And he's getting TPN, total parental nutrition. Guy's constantly getting septic, so we had to check the vital signs. If they're on antibiotic, how many days have they been on that antibiotic? I saw a 4th-year medical student just get blazed by the chief resident. You mean to tell me this patient's been on Zosyn and you don't know how many days the patient's been on Zosyn? He didn't have anything to say to them. He just looked at his shoes and was like, I felt bad for him. But I learned from that. I was like, I'm going to know how many days my patient has been on whatever, vancomycin, meropenem. So the patients, you would present it. And you have to know how to present. That's another thing. Know how to present your patient. And I got into a flow. It's almost like a rap for those of you who are rap aficionados. You want to do your initial assessment, then you go through maybe some relevant patient history. Is the patient, do they have a history of drug abuse? You start to see different signs and symptoms of withdrawal, like opioid withdrawal or whatever. So it's very, very complicated. If the patient had exploratory laparotomy, as a lot of my gunshot patients did, you need to know what it looks like. You need to be able to describe it. What kind of suture is it? What does the area look like? Is it erythematous? You'll learn terms like calor, rubar, tumor. Is there swelling? Does it look like it's getting infected? Does the person maybe have to go back in for some kind of emergency surgery? And this is where your anatomy really counts, guys. Don't sleep on anatomy. And I'm so proud of some of you guys who are on Instagram. You got these amazing notes that you're taking in anatomy. You have to know that. You have to know your markers. Especially your vasculature and your nervous system. As PA students, you're not going to get anatomy on the same level as a medical student. You haven't had gross anatomy or neuroanatomy. And again, this depends on the PA school to which you're applying or you're currently enrolled. But if it's your patient, you best believe your attending or your chief resident is going to ask you, well, hey, Mr. Abdul-Malik, this patient was shot in the stomach. What's the major vasculature that we're worried about? Answer is abdominal aorta. It's about the size of a garden hose. If the patient suddenly becomes hypotensive and you find out that there was a rupture, you need to know that. You need to know things like, well, they were also shot through the mesenteric arteries and the omentum and the small intestine. I think I'm going to do, maybe I'll do maybe an Instagram post of steps that helped me. Understand your algorithms when it comes to managing a surgical patient. If you have a patient that's going into surgery for the morning, get there early. I would say get there an hour early so you can review the case. I had a patient, we were doing a removal of a parathyroid gland. You need to know, what labs do you need to know for parathyroid? Know the physiology behind the parathyroid hormone. What's the significance? The attending started asking me anatomy questions as we're in surgery. Well, Mr. Abdul-Malik, what vasculature do we need to know about it as we're cutting into this person's neck? What nerves do we need to know? And I'm there like, But it just takes a lot of studying, and it's a very, very tough rotation. For me, I decided it was a rotation that decided I didn't want to do surgery because I would always wonder about what happened to the patient after surgery. I like long-term following up with patients, getting to know their family members, why they're there in the first place. But for some of you all, you may fall in love with surgery. That's all I really have to say about it. Oh yeah, and remember, that chief resident is not your friend. I don't care. For those of you all PAs, you may be older than the chief resident. Don't let that fool you. That is your boss. during that clinical rotation. You say, yes, doctor, no, doctor. If you haven't checked something, say, I didn't check it. I have no excuse. It won't happen again. And just take them chewing you out. But it's I wish you guys the best of success in your positive endeavors. I'm gonna do some more organized videos. I'm trying to multitask, but you can check me out on YouTube, Instagram, LinkedIn, Twitter, and I don't know, I might go to, oh yeah, on Facebook. Okay, take care. Oh yeah, and I'm also available to look through people's personal statements for PA school. Take care, guys. Peace.